It's my great pleasure to welcome you to Penn's 2026 Albert M. Greenfield Memorial Lecture. My name is Laura Perna. I'm Senior Vice Provost for Faculty here at Penn. Our Provost John Jackson had hoped to be here today, but our loss of Penn and basketball team is in Greenfield, South Carolina, rooting on our IB champion Quakers, hopefully to victory against Illinois. I'm very happy to be here. So today our lecture is going to feature a presentation and then a conversation with Lily Brown. Lily's director at the Center for Treatment and Study of Anxiety in the Perelman School of Medicine. He's also assistant professor of psychology in the Department of Psychiatry. She's going to be in conversation with JOSÉ BAUERMEISTER, who I hope you all know is our current holder of the Greenfield Professorship in the School of Nursing. Special thanks to the School of Nursing for hosting this event. Dean Villarreal will make some brief remarks and then introduce JOSÉ in a few minutes. So several members of the foundation and board I want to acknowledge before we get started. I want to thank them for all that they do to support this important and meaningful work. Priscilla Luce is the president of the foundation. Deborah Greenfield DeLaura is family member and secretary of the foundation. Albert Greenfield Jr. is family and board member, and I believe Edward Montgomery, board member, will also be with us today. A quick word about the Greenfield Professorship, which is unique at Penn. It recognizes distinguished teaching, research, and service, specifically with regard to intergroup and human relations. Both the professorship, now in its 54th year, and the lecture are funded by a gift from the Albert M. Greenfield Foundation, which supports activities that carry on the humanitarian vision of its namesake, Albert M. Greenfield. Mr. Greenfield was a longtime city leader who chaired the Philadelphia City Commission, Planning Commission, and many other civic and philanthropic organizations. Penn continues to be honored to host this professorship and carry on the important work of Albert and his family. So once again, welcome. And now without further ado, please join me in welcoming our Dean, Tony Villarreal, the Margaret Bond Simon Dean of Nursing in the School of Nursing.
Thanks, Laura, for being here, and thanks to everybody who's in the audience as well. You know, to live in Philadelphia is to be directly or indirectly impacted in one way or another by Albert Greenfield and his foundation's generosity and leadership.
It left the mark on our community, whether we're talking about Philadelphia Orchestra,
the Greenfield Library at the University of the Arts, which no longer exists, to CHOP and beyond. And the impact of their generosity here at Penn and Penn Nursing is absolutely evident. The partnership between the Greenfield Foundation and the university, which we at the school are proud to steward, is illustrative of nursing's own mission, vision, and values, which tasks us with embracing inclusion and innovation while promoting health equity. The synergy is evident and embodied in our Albert Greenfield professor, Dr. JOSÉ BAUERMEISTER, who embodies that legacy, and we are so pleased to have him here. As Dean of the Faculty of the School of Nursing, I see our faculty lead both as practitioners and visionaries, providing both treatment and transformation, practicing within the system and reimagining it, and that's exactly what JOSÉ does. I'm not sure if many of you know, but I've known JOSÉ since he was a master's student at the University of Michigan. When one of his philanthropists in Puerto Rico said to me, I have somebody that's coming to the university, will you take care of him? And I still remember, JOSÉ, one of our first meetings, and it was like lightning in a bottle. And I'll think of as wow, what is this guy going to do here? And so I have been pleased and privileged to witness not only his growth here, but to have him as a friend and as a colleague moving forward. The defining contribution of his scholarship is advancing community-engaged technology-enabled research and user preference science to strengthen biomedical prevention, mental health care, and chronic disease management, ensuring that emerging health innovations are not only efficacious, but acceptable, equitable, and implementable in real-world settings. Now, I'm not going to read his extensive CV, which has the usual accolades about the number of publications, grant funding, but one thing struck me today was not only his 40 million in federal funding, but his over 200 million that he has worked to support others in getting. And I think anybody who has worked with Jose, again, sees that generosity in spirit and mentorship and fellowship moving forward. Jose, just very proud of you in this lectureship. And again, look forward to introducing your colleague. And I will say the connection as intervention is just so timely in this post-COVID era, as I think we're all searching for that connection.
That I think hopefully moves beyond the technology.
So Jose.
You're aging when you have to switch from glasses to not glasses. Good afternoon, everyone. Welcome to this year's annual Greenfield Lecture in Human Relations. I'm Jose BAUERMEISTER. I'm a professor in the School of Nursing, and it's really an honor to host the annual lecture. The Greenfield Lecture holds a really special place at Penn because it invites us to reflect on questions that sit at the heart of human relations, how individuals, communities, and institutions interact, how trust and responsibility are negotiated, and how systems shape the conditions under which people live, connect, and thrive. The lecture series is named in honor of Mr. Greenfield, who was an extraordinary business leader, civic visionary, and philanthropist. If you have not read his biography, you should definitely read his biography. It's really extraordinary what he was able to accomplish in his life and beyond. And as has been said, the generosity of the foundation, this lecture was established to foster thoughtful dialogue about the social forces that shape our lives and the relationships and the communities in which we live. Now, human relations as a field of inquiry has always asked us to look beyond individual level behavior to the broader systems and environments that basically structure our human interactions with one another. It challenges us to consider how institutions create opportunities for connection or the barriers to connection, and how it's our collective responsibility to ensure our collective well-being. These questions feel particularly urgent today, if more than ever. Across the US and globally, young people in particular are navigating a period of extraordinary complexity. Their social landscapes are shifting rapidly, technologies are transforming how we connect with one another, and many of our traditional institutions are struggling to keep pace with these changes. At the same time, the rates of distress, loneliness, and suicide among youth and emerging adults has risen in ways that demand serious attention. Now, addressing these challenges requires more than an individual level solution, as you can imagine. It requires us to think carefully about the environments in which young people seek support, the relationships they rely on in moments of vulnerability, and the systems responsible for responding when distress becomes visible. In other words, it calls us back to the core questions of human relations. Now, this year's lecture focuses on youth suicide prevention and explores how emerging approaches, particularly those that leverage peer support and evidence-based interventions, may help us rethink how care and connection are organized in contemporary society. In moments of acute distress, the difference between isolation and connection can be decisive. Crisis response systems, from clinical care to national lifelines, are designed around that insight. Now, the challenge before us is ensuring that those systems are equipped to meet people where they are, particularly when young people are navigating stigma, identities, and uncertainties. We are therefore very fortunate to have with us today a scholar and colleague whose work has significantly advanced our understanding of suicide risk and mental health, and in the development of effective interventions for individuals experiencing acute psychological distress. Dr. Lily Brown is an assistant professor of psychology and psychiatry at the Pearlman School of Medicine and is the director of the Center for the Treatment of and Study of Anxiety at Penn. She is a licensed clinical psychologist whose research focuses on the development and implementation of treatments to reduce suicide risk, particularly among individuals living with anxiety disorders and post-traumatic stress disorder. Her work also examines the mechanisms of change in evidence-based psychotherapies, including cognitive-based approaches, exposure-based treatments for anxiety, and obsessive compulsion. She's going to hate that I'm going to go plug for her new book, but she just recently published a book titled Optimizing Cognitive Behavioral Therapy for PTSD, where she analyzes common challenges that practitioners face and proposes solutions for clinicians which can enhance patient outcomes. Dr. Brown completed her doctoral training in clinical psychology at UCLA, where her research examined fear learning and extinction processes relevant to PTSD. And since joining Penn, she has led a growing body of research focused on improving access to effective treatments, advancing suicide prevention strategies, strengthening systems of care for individuals at elevated risk, and being a terrific colleague and partner. Meaningful progress in suicide prevention requires more than insight alone. It requires systems capable of responding with care, coordination, and evidence-based practice when people are most vulnerable. And in fact, that's why I chose Lily to be the scholar today, so that she can remind us that prevention is not only about understanding risk, it's also about building knowledge, tools, and relationships that allow us to respond when it matters most. So please help me welcome Dr. Lily Brown to the stage.
Turn on my lapel mic. I don't want to forget that. Is that on? Yes. Okay. It is such an honor to get to be with you all here. And I just want to start by thanking JOSÉ BAUERMEISTER, who's one of my favorite mentors I've had in my, oh, that's okay. Oh, thank you for not letting me go through a talk with that on the back of me. I appreciate it. JOSÉ has been one of the most important mentors I've had in my career. I first got connected to JOSÉ right after I had my first baby, and that was April 2020. And it was a chaotic mess of a time for you all and for me too. And JOSÉ has this special way of making me feel seen and smart and like I have something to contribute. And I'm just so grateful to you and thank you for the invitation today. We are going to spend some time talking about digital connection and enhancing connection, all with the goal of suicide prevention and helping the younger folks in our community to find a way to build a life worth living and to feel confident that they have people in their corner to help them as they're working toward their goals and building their life worth living. And JOSÉ and I have designed some strategies in partnership that is all around leveraging technological options to help us in that goal. So without further ado, what do we know about youth suicide? When we look across the country in the rates of suicide across all ages over the past several decades, you see a really concerning trend. We see that over time, despite the fact that millions and billions of dollars have been put into the problem of trying to help people with suicide challenges, that we haven't made a major dent in these rates. We've seen some years where rates dipped, but then unfortunately slow but steady increases thereafter. And so this is a huge problem that's plaguing us in the field of public health and in mental health as well. And we need to be thinking about ways to design universal prevention strategies and also targeted strategies to help to address risk for the people who are struggling with disconnection and other risk factors right now. When we look at rates of teen suicide by state, we see some trends that mirror trends across the lifespan. We tend to see across all people that in the United States, rates of suicide tend to cluster in the western part of the country. Anyone have any preliminary thoughts about why we might sometimes see higher rates in that part of the country?
There are less people in that part of the country.
So there are fewer people, but still this is point prevalence rate. So connection is harder, which is a part of it. Anyone else have other thoughts?
Access to guns?
Guns. Firearms are a major contributor. And when we look at the ways that people choose to end their life, we know that when someone is selecting a firearm as a method, that's an extraordinarily lethal method. There are lots of factors, though, that contribute to a person's decision about whether or not they want to live or die. And we know that just because someone's thinking about suicide doesn't mean that they're going to act on those suicidal thoughts. And so there's a lot of factors that we need to better understand for prediction and interrupting of risk over time. When we look at leading causes of death by age, this is the top 8 leading causes of death by age. This is from 2023 statistics. Suicide here is reflected in the green box. And so what you see is that it starts to pop up in the top 8 causes of death around that 10 to 14, so early adolescence years. And this is sometimes surprising to clinicians who might think that that's a pretty young age for people to start thinking about suicide. Those of us who are on the P50 through the School of Medicine know that Dr. Rhonda Boyd over at CHOP had a grant through our program where they were seeing folks as young as 6 in the ER at CHOP struggling with thoughts of suicide. So we know that suicide can affect folks across the lifespan, but it starts to really rise in terms of a concern around that early adolescent stage. And you can see that that window in early adolescence and into young adulthood is a time that's of particularly high risk. And so when we're thinking about everything that's changing for a person during this window, there are so many developmental changes that are happening and so many lifestyle changes and also hormonal changes that can have a major impact on an individual's sense of their confidence that they can cope with stressors, but also in their network of who they can turn to when they're under experiences of stress. And so we need to be thinking about how can we design and deliver interventions that are helpful for folks in this young adulthood and early adolescent age range. Fortunately, there are evidence-based practices that can really help with suicide prevention at an individual level. While these evidence-based practices have been developed to be helpful in an individual therapeutic landscape, they haven't necessarily tapped into a population-level risk reduction. So these practices can be helpful for an individual clinician, but we need to be thinking about more community-based practices as well. But what do we know about what does work? Well, there are some really fabulous comprehensive packages that have been developed over the years. The one that people think about the most is called dialectical behavior therapy. This is a wonderful therapy that is really effective. It also has a lot of research supporting its efficacy and effectiveness in naturalistic settings. But there are cons to this approach. It's a really time-consuming therapeutic approach. For those of you who don't know, DBT involves coming for individual therapy and group therapy and potentially phone coaching, plus your therapist has to participate in a consultation group every week. So as a result, this is a really time-consuming and expensive package that can really help, but scale becomes a challenge. Also, the practice was developed for people who have a specific kind of disorder called borderline personality disorder. And borderline personality disorder can increase risk for suicide, but there are lots of people who struggle with suicide risk factors who don't meet criteria for that disorder. There are also some traditional therapeutic approaches, and by traditional, I mean like, once a week therapy in an individual format. And a great example is cognitive therapy for suicide prevention, developed here at Penn, and also brief cognitive behavioral therapy for suicide prevention. The pros of these options are that they are effective and they are well studied, and they're shorter and less expensive than DBT. However, they're still time consuming and expensive on the whole. Some fabulous brief interventions have been developed and have been fairly widely implemented in recent years with mixed success. One of those is a safety planning intervention. This is an intervention that was developed by Greg Brown here at Penn and Barbara Stanley, who passed away a couple of years ago. This intervention is available in a template form here at Penn Medicine, so that a clinician across the health system can pull up a safety plan and complete one with patients in real time when they learn that a patient is at risk. There are other forms of brief interventions as well. The crisis response plan is another one, also designed as a single session intervention, meaning I have a patient who's sitting with me. I learned that they're at risk. I want to do something right now to try to reduce risk, for instance, in an assessment with the patient, or maybe in a situation where I'm not going to have repeated contacts with the patient. These brief interventions can be fabulous and really helpful in those cases. Pros of these are that they're effective, they're brief, and they're widely implemented, again, with mixed success. Cons are that some of these interventions, while designed to appear like a single session intervention, are actually best delivered when there is the possibility of following up with someone to check in about, hey, how did that go? How's your plan working for you? What's getting in the way of using it when you need it, etc. Patients report in research that it can sometimes be hard to use their plan when they're in crisis. And this is based on a lot of research as well, that when a person's in a suicidal crisis, executive functioning really suffers. It's really hard to make a plan when you're in an emotional crisis. And that's especially true when you're in a suicidal crisis. People can also get tunnel vision, where it can feel like the only thing that they see in that moment of crisis is suicide as an option. And when you're in that tunnel vision mode, it's even harder to remember, hey, I have this plan, maybe I should pull it out and try to use it. Implementation of these packages also widely varies. So a lot of health settings have designed the safety plan for patient use, but how that's delivered varies a lot. So we did a study a few years ago in veterans, and every veteran that we recruited into the study had a safety plan per their report. But when we asked them, what is on your safety plan? What was it like making that safety plan? It was really variable. Some veterans said, my clinician at the VA, collaboratively helped me make this plan. It was really helpful. Other patients said something to the effect of, yeah, I heard of that, or my clinician told me to do it, but I don't really remember much about it. Or still other veterans saying, yeah, I made it, but I don't really remember where I put it. And so you can see how this can lead to all kinds of barriers in terms of making this practice, which could be helpful, actually helpful in crisis when you need it. There are also some community options that are available as well. You probably have heard of 988, which is a fabulous resource that people can call into. There are other examples of call centers or tech centers or chat centers that are available as well. The Trevor Project is an example targeting LGBTQ youth. And there are lots of other hotlines that exist for this purpose, more in the past than currently. And so the pros of these community strategies is that they're widely used, and in theory, they're universal prevention strategies. The cons, a lot of these strategies have been implemented without actual data suggesting that they work. And that makes sense because as a community, we look at these rates of suicide and we are alarmed and we're saying we need to do something. Why not build up these, strategies to try to reduce risk? But sometimes implementation gets ahead of the evidence, and that is by and large the case with some crisis call centers, that we don't have strong data that they reduce risk. We have data that people sometimes feel supported by these call centers and that people can self-report that it feels helpful. We don't yet know that they actually do reduce risk, which is interesting and concerning. The funding is really uncertain for these. And a lot of states are tasked with a requirement to have these call centers, but without any funding to help stand them up. Finally, the call that an individual receives when they make a call might depend on their training. So for instance, if someone's answering who has a lot of experience in suicide risk assessment and evidence-based safety planning, that caller might be really well suited for helping mitigate a crisis. But perspectives vary on what kinds of strategies should be used on these calls. And so how the implementation happens on these calls is also really heterogeneous. So what are some of the challenges with existing prevention efforts? We see lots of challenges. These range from workforce-related challenges, challenges with fidelity to what seems to work, and also challenges related to the need for follow-up. I'm sure some of these challenges are the kinds of things that you might deal with every day. And when you're concerned about a patient, when you're thinking about what resources are available for them, I'm willing to bet that these are the kinds of things that you come across with some regularity. For instance, on the workforce side, there are not enough mental health providers now. There probably will never be a sufficient amount of mental health providers to be able to meet the demand for services that exists. And so while we can do a great job in training mental health clinicians, when wait lists are really long, and when insurance is a barrier, workforce-related challenges are a major concern. There may never be enough people in the workforce to be able to satisfy the need that we have. And this is becoming especially alarming right now. In clinical psychology, for instance, we've seen a slowing down of admissions into programs because funding is challenging. And so, for instance, my cohort at my grad program had 14 students. Last year's had 3. And so we know that there's a workforce shortage, and the concern is it's going to get worse. There also tends to be a bit of a default into the status quo in terms of what the workforce does in their practices. So, for example, there is a history in suicide prevention of using a strategy called contracting for safety. I'm curious if you've ever heard of that strategy. Could you raise your hand if you heard of people talking about contracting for safety? So this is a practice that research shows is iatrogenic. It actually increases risk for suicide. Despite that, it is still in wide and regular use. 3 weeks ago was on a consult call with a psychiatrist who referenced that their patient was safe because they contracted for safety. And so while it's been, I don't remember exactly what year, Sherry, I don't know if you know when some of the studies were published showing that this is an iatrogenic practice. My recollection is at least mid-2005 or so. So it's been maybe 20 years that we've known that this is not helpful, and yet it's become so ingrained in the workforce that it's hard to move away from one of these status quo practices. Another challenge is non-assessment. So we're not going to be able to intervene to reduce suicide risk if a clinician is nervous to ask about suicide risk, or feels like it's a role violation, or feels like I'm not going to know what to do if I get a yes, so maybe I won't ask at all. And not everyone wants to come in for traditional mental health therapy. And some of the work that Jose and I did, the participants in that study that we're going to tell you about, reported this with some regularity. I don't want my parents to know that I'm in therapy, and because I'm on their insurance, they'll get information about that. There are workarounds for that, we've learned, but not everybody wants therapy for insurance-related factors or privacy reasons or stigma. And so workforce challenges remain a major concern. There's also challenges with fidelity. So even well-meaning clinicians can use prevention efforts suboptimally. So even clinicians who are trying to do these practices with fidelity don't always know that they might be doing things that aren't helpful. So for instance, a common example is, I did safety planning with a patient. What did that look like? I passed the patient the worksheet and said, hey, here's this plan, fill it out. That's not how the intervention was designed to be delivered, but that is how it sometimes happens. Also, some clinicians will not really personalize their plan. They'll say, these are things that work for people. Maybe you should try these strategies. They might not give a rationale for why a safety planning intervention can be helpful. And so the patient is thinking, is this just like a Band-Aid? How is this actually going to help my life or make my life better? Without realizing that the rationale is these suicidal crises are time limited. If we can come up with a plan that's personalized to you in advance, we can come up with some strategies in advance to reduce risk, to help you stay alive until the crisis subsides. But if that rationale is not shared, it can feel like a patched together or a not very thought out plan. Some clinicians rely on really directive strategies. So they'll say things like, I want you to just put this on your plan. And the patient will say something like, I would never call a crisis line. And the clinician might say, well, just do it anyway. Just put it on there just in case. Or the patient might say, I would never present to a crisis response center. Likewise, the clinician might say, well, but just in case you need it, let's just put it on anyway. And to the patient, this is read as you're not listening to me. And that's especially potent when you're an adolescent and you're very often positioned to not be listened to by people in the community. And so that approach isn't recommended. Also, patient fidelity is a challenge. And what do I mean by that? If a patient doesn't know where their plan is, it's not going to help them. If they don't think to use the plan in crisis, it's not going to help them. And if they don't update the plan based on what's working or what's not, the plan's not going to be helpful. Follow-up is also recommended for a lot of these practices. But despite the fact that it's recommended, it doesn't always become available for patients. And remember, across all presenting problems for mental health care, the average number of therapy sessions is 1. So on average, in most therapeutic relationships, you get a one and done opportunity. Now, I certainly hope that we could do lots of things to improve the likelihood that patients will come back. Sometimes those are experiences where a patient is deciding that this isn't a good fit and therefore I won't come back. Sometimes there's financial reasons why that makes sense. Sometimes there's clinician reasons why that is the outcome. But the reality is we get these limited windows of opportunity to help people. And so we need to capitalize on those opportunities wherever we can. So we can use principles of implementation science to help us in thinking through ways to overcome some of these barriers. So how can we, for instance, leverage implementation science to address gaps in the workforce? Using strategies like task sharing, for instance. What are evidence-based practices that could be delivered by trained peers, for instance, or lay professionals? How can we think about strategies from implementation science to bolster fidelity, to make it easier for clinicians and members of the workforce to do things as effectively as possible? How can we use implementation science to improve the acceptability of the interventions that we're delivering and to improve the alliance, that is the connection between the youth in front of you and the clinician? Also, how can we use implementation science to alter social norms about what is the kind of thing that another youth in your situation might also consider doing to help them manage their risk? So peer support comes to play when we're thinking about lots of fabulous ways to intervene for some of these barriers that are major challenges in our field. So the promise of peer support cuts across all of these domains that I mentioned before. There are way more possible peers that we could think about training than there are clinicians. We also know that once a clinician becomes seasoned and very expert and skillful, they start to rely on their clinical experience, which can be a really good thing, unless information that's available from science changes. And then the kind of thing that I'm defaulting to as an expert clinician might be out of practice. And despite the fact that it's maybe even learned to be iatrogenic, like contracting for safety, I'm still doing it because that's what I've always done and that's what I think works. So expert level experience may or may not promote fidelity to evidence-based practices. And it might be the case that when we're working with less trained people like peers, that they might be more open to feedback and strategies to make sure we're staying on track in terms of principles of evidence-based practice. Peers are also more cost-effective, which can allow for us to think about strategies to build in repeated follow-up opportunities beyond that clinician encounter. Peers can also help to build trust to encourage return visits. So we can think about strategies to coach peers to build rapport, to build trust, to make it so that the patient actually wants to come back, to prevent that one and done window of opportunity that clinicians often struggle with. So this really is the foundation for STARS, which is the intervention that Jose and I developed for suicide prevention. And we're going to spend the rest of this talk talking to you about STARS and what we learned from this project. This was part of a P50 Center grant to Dr. Maria Kendo and Greg Brown in the School of Medicine that had 3 aims. The first aim was to understand the landscape of existing suicide prevention opportunities for LGBTQ plus emerging adults, and to use a specific framework that I'll tell you more about to understand what exists now, what of the opportunities that exist are helpful for implementation, and what might need to be adapted. Our second aim was to look at preliminary efficacy and mechanisms of action of STARS relative to a control group. And the third aim was to examine evidence of implementation outcomes among emerging adults who identify as a sexual or gender minority. So this is very much a collaborative project. And so Jose and I are the PIs on this project, but we had so many fabulous team members, some of whom aren't even depicted here, who really made sure that this project was successful. The design of the study was that we recruited emerging adults between 18 to 24 who identified as a member of the LGBTQ community who had past month reports of suicidal ideation. After completing the baseline evaluation, all the participants received the safety planning intervention with a clinician. Then they were randomized to either safety planning alone, our control, or STARS, which we'll tell you more about in just a moment. Then we repeated the assessments 2, 4, and 6 months later. The ADAPT-IT framework is one that is heavily used in HIV-related intervention adaptation processes. It's a strategy for systematically understanding the landscape of interventions that exist and evaluating what of those interventions is helpful and is a potentially good fit for this context or this population. What pieces can we take from these existing evidence-based practices, and what might we need to make some changes? And so we went through, over the course of a year, a process of getting feedback from our youth advisory group. These were people who were age matched to our future participants, so between that 18 to 24-year-old age range. And the youth advisory group helped us make sure that what we were designing would be palatable and acceptable and potentially helpful for future participants. We also tapped into the expertise of our technical expertise group. These are people like directors of local clinics throughout Philadelphia, people who serve LGBTQ population, and people who are experts in suicide prevention. After we designed this adapted intervention, we then tested it. So the intervention that we use as the foundation of the work is a safety planning intervention, which I've already alluded to. If you're not familiar with this intervention, it includes really 6 key parts. The first is recognizing warning signs for suicide. Now, importantly, this isn't just warnings that I'm going to be in a bad mood or that I'll be anxious or depressed. This is what about your experience is the sign that you're transitioning from having, maybe lower intensity thoughts about suicide to suddenly higher intensity thoughts about suicide? What's the specific thought that goes through your mind in that moment? What's the behavior that you notice yourself doing, or the physiological sensation? That's the trigger that it's the time to take out your safety plan. Step 2, what are some internal ways that you can distract yourself? The idea here is, what are some things that you can do that it almost makes it hard to simultaneously do those things and think about killing yourself? How can you turn to people in your support network for distraction? These don't necessarily have to be people that you would feel comfortable, bearing your heart on your sleeve to, but who are the people that you can call up and have them tell funny stories to you? The kind of people who always have something weird happening to them that when you call, you're like, that was not a story I expected today. People who are good for distraction, or places that you can go to for distraction. Step 4 is, how can you turn to your network for help? Are there people in your network that you'd feel comfortable saying, I'm having an awful day, can I talk about it? Or I'm thinking a lot about suicide today, can I talk to you about it? Step 5 is about professional support. So this looks like, if you have members of your treatment team, could you see yourself actually calling them in a crisis? You'd be amazed the number of people who say, yeah, I have a psychiatrist, but I would never actually call them in crisis for a variety of reasons. Of course, other people would say, I absolutely would call my psychiatrist. It's really variable, but we can't assume that just because you have a team member that you would use them for suicide prevention when in crisis. This can also include crisis call centers. Most of the participants in our study had used a call center at some point or time. Lots of people had used the LGBTQ hotline, the Trevor Project, 988, and those experiences were really variable. Some participants said things like, it saved my life. The person on the end of the line was so helpful. They listened to me. All I needed was a little bit of connection in that moment. To the other end of the spectrum, where people said, I was on hold for 40 minutes and no one ever answered the line. Or the things that people were suggesting on that line weren't helpful to me. I felt not listened to. So experiences were really variable. Then step 6 is all about changing the environment. And the idea here is, what kinds of things about your environment might you need to change proactively so that in a future crisis, you don't have such easy access to really lethal means? This doesn't mean getting rid of lethal means. It could, but it doesn't have to. So for instance, instead of defaulting to, well, let's wag our finger and say guns are bad. No, this is, how can you alter your access to your firearms? So I work a lot with people with PTSD. A lot of people with PTSD have guns, and they have guns because they feel that it's going to keep them safe. And so I lose credibility as a clinician if I'm trying to lecture them to get rid of their weapons. Instead of that message, the message is, how can we change your access to it? That can look like a gun lock. That can look like a gun safe. That can look like storing your ammo in a different location. What would it look like for you? What are you willing to do? What are you not willing to do? Other examples are things like changing access to medication. So taking your medication bottle and putting it in a little pill pack. You'd be amazed that the idea here is just slowing down a person so that when they're on the one-track mind where they're thinking, all I want to do in this moment is kill myself, we want them to have the gift of time to allow for executive functioning to come on board. And any strategy that can help slow time down can be helpful in reducing risk. And there are some things in the environment that we can't change. For instance, I worked with someone who had a shared living environment, and they had shared knives that were owned by a roommate. They can't get rid of their knives, but can we put a reminder on that method that is a cue to you to try to get out of that tunnel vision mindset? So these are all examples of things that we talk about when we're building a safety planning intervention collaboratively with patients. in STARS, what we did is we took this, this foundational application through JOSÉ's iReach program, and we built a homepage, which you'll see is the one that's scrolling on the left there. And we have opportunities for patients to create goals and strategies for, making sure that they're feeling supported and setting goals that are important to them. We took their safety plan and built in to the app their personalized safety plan so that they could turn to that really quickly in crisis, and they could also edit it and modify it. We have tons of resources for support and learning, tons of articles and activities. We also have forums through the STARS app. And all of this some of this is targeted toward suicide prevention. Some of this is targeted toward general life skills, things like how to apply to college, how to have a healthy dating relationship. And then a care locator based on resources here in Philadelphia that people could turn to if they're feeling like I need more support. And so lots and lots of fabulous resources built into the STARS app. So participants in this study, demographic factors are reported here. We recruited 64 participants into the study. We had planned to recruit 60, and we actually over-recruited. And this is the only study where that's ever happened to me, that we got more people than we wanted. Usually we're like begging to get enough people. We barely make our targets here. We had the opposite problem, which was a really encouraging sign that we're onto something here in terms of a potentially palatable intervention for folks to participate in. If we looked at the results of the study, so first, the result I'm going to share with you is about utilization or use of the safety plan. So the question here to participants at 2, 4, and 6 months was, are you using your safety plan? And we're looking at, again, people in the safety planning intervention alone group, that is, they built a safety plan with a clinician, versus people who got access to our STARS condition, which included access to our app and 6 peer mentorship sessions. And before I show you these results, I'll just say that peer mentorship sessions were designed to help with overcoming obstacles to using the safety plan. So every session, the peer mentor would talk with the participant about, how's it going in using your safety plan? What aspects of it are working well for you? What's not working well? Have you been using it? If not, why not? What do we need to change about it to make it more helpful? Plus, using other content from the STARS app to help the person build a life worth living so that they had fewer crises. So for our safety plan utilization data, what we found was that participants who were in the STARS group were significantly more likely to actually use their safety plan than participants in the control group. So there's 32 in control, 32 in the STARS arm, and a significant effect here. So what we're seeing so far is that when we give additional digital and peer mentorship support, it might enhance participants' willingness to actually use their plan, which is a really positive signal. In terms of our efficacy data, this is using the Beck scale for suicide ideation. What we have here is our STARS group in red and our control group in blue. And so we can see that both groups had a significant reduction in suicidal ideation. We would hope to see a reduction. We were expecting to see a steeper reduction in STARS than in control, which we didn't see here. But we do see that there's this non-significant trend in the STARS group to continue improving in terms of suicidal ideation, versus in the control group, a bit of a reverse course and a slow crawl back to baseline. So potentially some preliminary evidence that STARS can be helpful in maintaining gains in suicidal ideation. We also found some evidence for potential preliminary mediation. And this effect was such that when we looked at actual utilization of the app, here we were looking at actual clicks on the safety plan in the app. Participants who clicked more on their safety plan had a greater reduction in suicidal ideation over time, which is interesting. And it's one of the first studies of its kind to actually look at the relationship between real-time use of the safety plan and reduction in risk, which is a really cool preliminary finding as well. In terms of our suicidal behavior outcomes, here we have our control group on the left side and our intervention group on the right. This is at 2, 4, and 6 months, just the presence or absence of suicidal behavior. We're woefully underpowered to look at group level differences in this outcome, but we certainly don't see any evidence that STARS is increasing risk. That might sound like a ridiculous idea, like why would it be the case that your intervention would increase risk? What we're doing here is we're having peers talk to suicidal patients and help them with overcoming obstacles to using a plan in crisis to keep themselves safe. There is always the possibility that such a strategy that's kind of more novel in that way could potentially be iatrogenic, and we're not seeing any evidence that that's the case, so that's really encouraging. We also looked at data from the peer mentors themselves. And so the peers were, participants were randomized to get either the peer mentorship or not. And the peer mentorship was delivered in 6 sessions. Every participant could get up to 6 sessions. And every session we asked the peer mentors, how was that for you? What was your level of distress during the intervention? How comfortable did you feel? And we also checked in about fidelity. That is, how well were the peers doing at delivering this intervention, how we asked them to. And then we checked in with the peer at 2 months about their sense of how peer mentorship went, and also looked at rates of completion from the peer mentor in terms of their sense of acceptability and their sense of appropriateness and feasibility of this intervention. And so what we find here, on the top, we have the reports of comfort ratings by session. And so this is on a scale from 1 to 10. How comfortable did you feel during this peer mentor session? This is for the peer mentor. And what we find is that participants, this is peers, on average peer mentors rather, had pretty high ratings of comfort in the session. And again, you might be wondering, well, why do we care about this? So peer mentors, in theory, are people with lived experience, potentially with histories of suicidal crises themselves. And so it might be the case that by talking to a participant with acute risk, that could activate risk in the peer mentor. And so we're really wanting to be intentional about assessing this. Also, ratings of distress in the yellow box were low. So both comfort and distress ratings indicated that peer mentors were saying, this is a good idea, that we should be doing this, that this is helpful, and I feel okay in doing this. Jose and I were asked 2 Februaries ago to participate in a workshop that NAMH was doing about peer mentorship and suicide prevention. And it was interesting because peer mentors on that call said something to the effect of, why are you all so concerned about the peer mentors? Would you be asking this of clinicians? And the potential sense that maybe we're patronizing peer mentors and asking these kinds of questions. I think the reality is we should be asking clinicians these kinds of questions, because the reality is it is hard to be sitting across from someone who's suffering so much that they're seriously thinking about taking their life. That's a really stressful thing. And so we should be asking this of clinicians. We often don't, but we should be, is my answer to that question. Peer mentors also had fabulous fidelity. So we were listening, me and one of the fabulous counselors on this study, Jess Webster, were listening to sessions, audio recordings of the peer mentor sessions. And we rated them for content, that is, did you do the things we were asking you to do in the session? And also style, that is, how well did you do them? There's some research in therapy that sometimes it matters less what you do and more how you do it, which makes sense. There's this sense of, competence and your sense of being able to be with the person across the room and not be in your head and thinking about the next thing you're going to plan. What was really encouraging about these fidelity ratings was that they were high for both content and style. I was blown away listening to these peer mentors and how skillful they were in delivering this content. And so it was really encouraging. We also asked the participants how confident did they feel talking to a peer mentor, and were the sessions feasible for them in terms of their schedule, and ratings on both of those metrics were also high. In terms of the data for surveys for peer mentors, we asked about acceptability, feasibility, and appropriateness. All of those metrics were high. We also did qualitative interviews with peer mentors. And what we found was really interesting feedback. So for instance, peer mentors reported, I was very prepared to do everything in relation to the discussing of safety plans and sort of working to brainstorm a safety plan that wasn't quite working with somebody. Another peer mentor said we did a lot of role plays and I felt that was very helpful in preparation. But also some feedback that suggested room for improvement for next time. With some participants, I would always have to reach out in between sessions because they'd miss a session or they'd be late, and I'd kind of reach out multiple times asking if they were coming. And then another one, I think some of the sessions felt a little bit more like jam-packed with content than others, but that also depended on the person that they were with, and some people really had nothing to say. So room for improvement, and to us, this indicates a need for coaching the peer mentors to be really responsive to the person sitting in front of them in the room, as opposed to having a script each session to just follow. So how has STARS changed our thinking about youth suicide prevention? Lots of ways. First of all, these findings suggest that digital peer mentorship is an acceptable strategy to use. Recruitment exceeded our goals, suggesting that people are willing to do this, which is great. We also found that the peer mentorship is feasible. 81% completed all 6 of their peer mentorship sessions. So that's an incredible rate of completion. Digital peer mentorship was also successful. It increased use of the safety plan. And there's a signal for improved maintenance of suicidal ideation. Peer mentors are really good at this. So if we can train them and give them the right support, I have every reason to suspect that peer mentors will thrive in this role if we set them up for success. They have really high fidelity to the protocol. We also found that the strategy was safe. We didn't have any adverse events or any suicidal outcomes in the study. We found that there's a need for us to do some streamlining going forward. Some sessions are hard to contain in terms of the amount of time and the content that was packed in based on the time. And so that's something we'll be improving in our next iteration. We also noticed a need to really make sure we're personalizing everything that we're doing in this intervention. Not every topic is a good fit for every person. And how does a peer mentor respond when a topic isn't feeling like a good fit for the person sitting in front of them? The biggest takeaway I have from this project is we really need to be doing this yesterday. We really need to start right away rolling out peer mentorship across the health systems throughout the city. Peer mentorship is covered by insurance. There's a Medicaid code to allow for billing for peer mentorship. And so this, I think, is a critical need that we need to make sure this is happening regularly and stood up across the city. So where do we go from here? Lots of future directions for us to be thinking through. I think it's time for us to go big or go home. We are working on efforts to scale this through, I don't know how many grants Jose and I have put in to try to scale this up larger. We've got some great strategies for scaling this up across the state, and there's some possibility that state level funding will be on its way to support a scale up. We also got preliminary signs from NIH that they might be funding a larger scale version of this project, but too preliminary to know for sure. But we really are hoping to be able to do this in much larger numbers soon to know whether this works at scale. We need to be thinking about personalizing everything we do. Anytime a clinician is recommending a practice just because I want this patient to do this thing, that's the kind of message I want them to move away from. And I want us to really instead be more thinking about how do I connect with this real person in front of me to make sure that the message that I'm sending is palatable and helpful and relevant for the crises that they're having. How can we use things like, for instance, digital assessments, like ecological momentary assessment? One of the grants that Jose and I are working on now is about regularly pinging patients throughout the week to ask about how their moods are doing, how their social support is feeling, how are they in terms of their suicidal crises. Also, how did your peer mentor session go? And based on the feedback that we get from those reports, delivering feedback reports to peer mentors to help the peer mentor get more support in deciding how best to spend the time next week based on clinical data that's coming in for the patient, and also patient report about how the peer mentor session is feeling. Feedback is a critical part of collaborative mental health care. Clinicians are often trained to ask for feedback, to check in with your patient, how was this session for you? What did you like? What did you not like? The reality is that it's not as regularly implemented as it should be in theory, and that's true in clinical work. That's probably also true in peer mentorship. So we want to make sure that youth have agency to say, I like this is helping me, or I wish that this was different and here's how I want it to be different. So these near real-time feedback reports we hope will be helpful in making sure that participants and youth in particular feel heard and like they have agency over how their treatment will be spent. So for instance, asking questions like, how was that for you? How are you in general? We're also interested in aging down some of this work. We started with the 18 to 24-year-old age range, in part because we wanted to avoid situations where we had to reach out to parents of LGBTQ youth and potentially risk, confidentiality concerns related to the content of the study. But it's clear, based on what we saw in the risk in terms of the top 8 causes of death, that we need to really be thinking about strategies for making sure that adolescents can get incorporated into the fold with this work going forward. And we'd love to partner with you all if you have a particular interest in that topic as well. So how do we support youth given everything that's happening right now? We've talked through a lot of things in terms of what we know about what's happening in terms of the rates over time, what we see in terms of risk factors across different states in the country. We think that there are certain federal level risk factors that are also really relevant right now. We know there's also lots of challenges in the funding landscape. For instance, funding's going away for certain crisis centers and certain crisis call lines. How can we think about designing and implementing resources that will meet the reality of the multifaceted challenges that we have? That's what Jose and I are hoping to talk to you about in the Q&A in just a few minutes. So I want to just highlight the fabulous work that the Eidos LGBTQ plus health initiative is intending to accomplish. And this is one of the projects that was done in partnership with Eidos, and also to make sure that you have the opportunity to connect with Eidos if you're interested and not already connected. And with that, I want to thank you for the time and attention and being here today, and turn it over to questions and answers. Thanks, everyone.
Thank you. So we have a healthy amount of time for conversation, both virtually. Thank you, James, for checking the Q&A on our virtual attendees, but also here in the room. So this is the time that I get to be Oprah. A few minutes and walk around the room. Hey, here I go. Dean.
Thank you very much. Got lots of questions here, but the one question I have, if this is if your original sample was LGBTQIA, what about the intervention was specific
to that population, and what opportunities are there to expand the core of what you've done to other populations?
Great question. Thank you. So the content was designed for LGBTQ emerging adults. And part of the way that we were thoughtful about that was by enacting this youth advisory group, which were basically then recruited to be peer mentors in the study. And so the idea was we recruited for positions for people to be paid to give us their feedback about what LGBTQIA plus youth would need in a suicide prevention intervention. And so people could apply for hourly employment based on lived experience. And so we'd ask them, for instance, why are you interested in supporting suicide prevention for LGBTQ plus youth? And we use that for making hiring decisions about onboarding them. We, in our peer mentorship sessions, had 6 sessions. So the first was always about checking in about the safety plan. The second was about values clarification and goal setting. And to the extent that issues related to identity were relevant, those would come up there. It might not come up there. The third session was around helping with dealing with negative self-talk. So to what extent do you find yourself getting in your own way with self-derogatory comments or saying things to yourself that you think make it harder for you to work toward what matters to you? The fourth session was around building positive experiences and behavioral activation. So what are some things that you might want to do to help build opportunities for a sense of self-empowerment and also pleasurable events? The fifth was about coping with discrimination, and that discrimination might be on the basis of a multitude of identity factors, including intersectional identity factors. And the sixth was about building and connecting to safe spaces and safe communities. And so that could include on the basis of an identity as an LGBTQ member of the community, or on finding other safe spaces. So this was kind of the skeleton of what the topic areas were. Nothing about the safety plan itself was changed on the basis of a person's identity, except that everything that we designed in an individual person's safety plan was curated to what they felt would be helpful. So for instance, when we're looking at what call centers they want to use, I asked them, have you tried, the 988 number? Have you ever called the Trevor Project? Have you ever called the LGBTQ hotline? And based on their experiences, we would either include those components of the safety plan or not. And so then on the STARS app as well, there's content on the app about, how to navigate family rejection and, find chosen family, how to navigate safe dating opportunities and things like that. So it was really folded into the app itself and to the peer mentorship sessions. I don't know if you have anything you want to add to that.
No, I'll only say that one of the things that was really helpful from a design standpoint is if we design for LGBT people because of the complexity, then the scale to general population is easier. That's one of the premises of what we do at Eidos is like we're designing with the benefit of one group to achieve equity for all. And so we've already gone through the content and made it general population because what young people were asking us, yes, it had to be tailored to the experience of an LGBT person, but I would presume that any young person would have very similar, it might look different, but the same drivers are going there. And so this NIH project that several of us are hoping for good news is actually a general population approach so that it can be rolled out through the entire Penn Medicine health system. And then we can train peer mentors to decipher and delineate how do you turn on different lenses and signals. So that's really exciting. I think the other thing I'll say as I start moving is we designed with purpose of cost. So we know that what we get in reimbursement through Medicaid actually would cover the cost of the peer mentor. So we're not creating deficit in cost by rolling this intervention. We actually get a little bit of, not a lot, but a little bit of money that actually then helps the digital platform sustainment. And so again, it is thinking about implementation as we think about it in Fidelity, but also what will Kevin Mahoney need to know, or Dr. Okendo need to know if we were to scale this as an evidence-based practice. Yep.
So interesting. I just have it's really a clarifying question. So the differences between the control and the treatment group. So did everyone have access to the app?
No, in this
Oh.
study, only the STARS group got access to the app. So everybody in both groups got the safety planning intervention with the clinician, and that was done on paper with everybody. Then after the clinician did that intervention, they got randomized to either app, in which we then populated their digital safety plan based on the paper one that they just made, plus the peer mentorship sessions, or in the control group, we just did ongoing assessments for the control group.
So did you consider whether the app alone would be effective?
This is something we've been thinking a lot about. And the reality is right now we have this package and we would love to do a dismantling study to know to what extent is it the app versus the peer mentorship? Do you really need both? And so we're interested in kind of unpacking that more. We don't know with this version. It's hard for us to unpack that with the design that we have now. And so we're interested in doing that in the future. We can't speak, I don't think, further to that right now. I don't know if you have anything you want to add to that, Jose.
I mean, that's the challenge, right?
Interesting.
With the NIH funded project, well, look at me getting ahead of ourselves. With the project that might get funded by, yeah, in theory, the larger project, everybody will have access to like a digital safety plan. And we will also be doing EMA assessments with everybody. But the app itself will be really only the safety plan and assessments in that control group, so that at least everyone will get the digital version of that. So we can at least speak to that in the next grant if it gets funded.
Thank you, Lily. This is awesome. And I love learning about this stuff. It's not something I get to think about on a regular basis on the surgery side. So 2 questions. So number 1, regarding the decrease in suicidal ideation in the control versus the intervention group. You mentioned how there is a prolongation of or a trend towards prolongation of the benefit in the intervention group, but you also mentioned that the slopes of decrease in SI were similar. So what are your hypotheses as to why that might be the case, and what are the kind of mutable points that could be targeted in order to change that?
Yeah.
So that's A. And then B is a little bit further afield. As you think about the role of a peer mentor and the role of a digital intervention in pinging someone in order to then kind of either engage with the peer mentor or engage with the app more frequently. There's lots of things that exist already in terms of our biometrics, right? People wear Oura rings and they can tell you if you're sleeping terribly. They can tell you if your blood pressure went up. Is there a plan to sort of incorporate that sort of thing as a trigger for pinging so that people don't just go ear blind to the ding that comes through that every Tuesday I'm going to hear this and I'm sick of it, but rather, hey, you slept really badly last night, and that was a really weird question, but I hope you followed what I'm saying.
That's a perfect question. I think you're spot on with where we need to be going down the road. So for the first question about maybe part of your question is, why did the control group also get better? And so the research on evidence for the safety planning intervention improving suicidal ideation is pretty mixed. The safety planning intervention definitely reduces suicidal behavior. That's a pretty well established, I shouldn't say definitely, but a lot of research is circling around the reality that that intervention seems to reduce the risk of suicidal attempts. The research on suicidal ideation is more mixed. And so in this study, it's possible that both groups had a regression to the mean. It's also possible that both groups had an improvement in suicidal ideation on the basis of the fact that they both did this intervention, which is a gold standard intervention for suicide prevention. And it's possible, when we were proposing this study, we were thinking about mechanisms of action of STARS as threefold. We were thinking part of it is social support, and that's why we developed the peer mentorship strategy. We were thinking part of it is also about positive affect, because there's some research to suggest that LGBTQ youth sometimes report lower levels of positive affect. That's like lower enjoyment of things, lower sense of connection to love on a daily basis. And the third thing was coping with discrimination. And so we were trying to design the content of STARS to address each of those targets, which we thought would then further improve suicidal ideation. So we didn't see that during the active window, but we did see ongoing improvement in that group. And so we speculate that those factors could be at play, but we're underpowered to be able to really effectively test mechanisms right now. So yeah, your question about biometrics, I think, is a really good one. We have a paper from a much larger sample of Marines, randomly enough, and now for a totally different story, let's talk about Marines. And what we found is that you can actually use machine learning to design this algorithm based on, in that study was Fitbit and ecological momentary assessment, to forecast transition points in risk. So when does a Marine transition from lower risk to higher risk? The challenge with that is you need a lot of data to have accurate forecasting. And if you have a lot of people, you can make pretty decent assessments about that. But for a given person, you need a lot of data about that person before the metrics start to work out in terms of increasing reliability for that patient. But your point, Cesar, about sleep is a really good one, because it's a lot of the research that we're finding about what is happening right before someone transitions in risk. It's all really circling around circadian rhythm disruption and sleep. So we've got a series of papers out showing that the middle of the night is the highest risk time for suicide. People are most likely to die by suicide in the middle of the night. That's been replicated across a variety of different populations. And in our research, people are also most likely to report that their suicide risk is worse in the middle of the night. And that's a challenge from an intervention perspective, because your clinician's asleep then. Your peer mentor hopefully is also asleep then, but your app can be awake and available to provide you with some resources and tools to help you with engagement during those windows. So I do think that the future will take us there, but I think you need a lot of data. The problem with needing a lot of data is burnout for the patient, who will stop responding at a certain point. And so there's this trade-off. You need a certain number of assessments to get a relatively accurate prediction, but not so many that people are going to stop responding. And that sweet spot, we're still trying to figure out what it is.
Thank you so much for sharing your amazing work. I find it really fascinating you're using peer mentor almost like interventionist. So I'm really curious about the before, during, after about the peer mentor. How did you the peer mentors and training they have gone through?
Yeah.
And during the process of the intervention, what kind of clinical supervision and support you provided for the peer mentor? And have you, after the intervention, look at the intervention effects on the peer mentor themselves, and whether some of the participants, when they graduate from the program, peer mentor for sustainability? So just curious about your thoughts.
Oh, that is a really interesting question. So we recruited peer mentors from our youth advisory group. So we sent out advertisements saying, hey, are you interested in working in a suicide prevention project focused on LGBTQ youth? Apply if you are. Why are you interested in working on this study? And then based on what people self-reported in that, we're able to kind of make personalized selections for selecting who should be a peer mentor. The question of who's a good peer is more complicated when you think about expanding. So for some of these studies that we're thinking about doing across Penn Medicine, it's going to be a lot harder to figure out who's an appropriate peer. On what basis is someone a peer? It's easier in this study because it's age and identity and experiences with mental health globally, potentially with suicide risk. And so it could be any of those factors. Training looked like the summer before we started the study, there was 16 hours of training. So it was basically 8 weeks of 2-hour training sessions. And the first 4 were led by James, who did a fabulous series of trainings on motivational interviewing, how to ask open-ended questions, how to make sure that you're reflecting, and all kinds of other fancy motivational interviewing strategies, which are beyond my level of awareness, because my role in the training was in training on kind of CBT awareness skills, with the idea that we're not training peers to be CBT therapists, but to know about CBT skills so that when they're running into challenges with, dealing with negative self-talk, that they feel like they could talk to someone about how thoughts interfere with our behavioral choices, for instance. Then every week we had group consultation meetings with myself and with another counselor on the project, where the peers would come and talk about, the peer mentors would come and talk about their sessions. We could listen to sessions together. There was role play in the training. They got to role play with each other so that they would, the training was set up that usually James or I would model a session, and then we would have them break out into breakout groups and practice doing it themselves. And we would record them so they could watch themselves back, which I think is the best strategy for teaching anyone to do any kind of interpersonal intervention, is watch yourself do it. Get over your embarrassment and mortification of watching yourself. Watch yourself do it, and you are the best strategy we have available at correcting problematic behaviors. We had a fidelity monitoring system where peer mentors, for the first 2 cases, we listened to every single one of their sessions and gave them supervision or consultation between sessions. And then once they completed those first 2 cases, a random selection of 1 session for every full participant was listened to for fidelity rating purposes. Then the last thing is we had some booster trainings. So after, I think it was 6 months into the project, we had James come back in to do some more motivational interviewing training and some additional kind of brush up strategies for some of the other CBT inspired principles in the protocol. To your question, though, about how did the peer mentors do, we didn't invite any of the participants to become peer mentors. What a cool idea, though. I love that idea of thinking about, connection to community and to values, and opening up opportunities for former participants to be connected to like a service role. I think would be a great idea. That's not something we explored in this study. We'd have to make sure we're very careful about like ethical problems with that, but I think there's a lot of potential to that idea. Have you ever done that for iReach or any of the other projects?
Cool idea.
It's a really great idea. Thank you.
So I also had a question related to the training of the peer mentors, but first I just want to thank you both for sharing your knowledge with us today, and it's been an honor to get to work with both of you, because I do get to think about these things every day, and I still have learned a lot. So my question, it relates to the scalability of the training program, and it seems like you had a very comprehensive, clearly effective package, and I wonder, I'm sure you have thought about how you could bring that to scale. And I had another question, but I don't remember it, so I'll stop there.
Are you thinking about training of the peer mentors? Yeah, gosh, it's such a good question. I feel like in my center, we do a lot of therapy trainings. And what we've learned in the literature on how to train therapists is that a lot of the things we've historically done don't work that well in terms of changing clinician behavior. And the typical way we train clinicians is what we call the train and pray model, where you say, here's how you do this thing, we really hope you do it. And that doesn't work. You might be surprised to find out training and praying is insufficient to change clinician behavior. Is that enough for peer mentors who are coming into that role? Maybe, maybe not. The implementation science landscape suggests that you really need consultation to change clinician behavior, which is why we made sure to have ongoing consultation for the peer mentors in this project. But I think questions about initial training and ongoing fidelity, kind of booster sessions, remains an open question, and one that I think is a really interesting question that we're going to have to explore further, because there's so much potential with the workforce challenges we have. There's so much potential to make an impact through peers, but how to do so in a safe and efficacious way, and in a way that doesn't burn peer mentors out, I think is lots of questions we need more answers to. Jose, what would you add to that?
Would Jose add to that? Brilliance. I'm not sure that I would. I mean, assuming that the renewal happens, the peer mentor there, we'd have a cadre of peer mentors who would actually be available not as a part-time hire, but actually would be working in the hospital. And so we'll have to think about, do we need 8 weeks? We did 2 weeks per week so that it was accommodating schedules of students and research assistants and peer mentors. If we are now moving in scale and scope, maybe we do a 2-day or a 1-day, but it does, Sherry, you bring a great point, because it makes us think like maybe we should even think of like a mini pilot inside of the project to start getting a kind of a signal to that, and see how that looks.
Yeah. And Sherry, if you have ideas too, do you have ideas about scalable training? Because you do a lot of training for suicide prevention too.
I see what you did there.
Not No. I think it's a question that I grapple with myself. I also remembered my other question, but I'll give Courtney a chance.
Hold on, Andy, and then Courtney. Go ahead, Andy.
Yes, quick follow-up question in terms of the sustainability issue for peer mentors. Do they age out of becoming a peer mentor? And does that mean that you have to have a constant pipeline of peer mentors to be trained? And if they are being aged out because they get older, could they be retained as trainers, basically, of the next generation of peer mentors? So that's one question. The second question is technology. So given concerns about technology being one of the drivers of youth mental health issues, and the fact that part of your intervention is technology-based, have you thought about that sort of conflict of relying on technology that could also be a source of triggers for mental health symptoms for young people?
Yeah, what great questions. So in this study, the recruitment for the clinical trial was only 2 years, so not enough time that these peers would have really aged out. But I think that as we're thinking about expanding our sample and doing a longer study, that is something that we'd have to be thoughtful about. And I think in general, as we're expanding our sample in our larger trial, I think it's 18 to 29. And so, then we need to think more carefully about who can be a peer for which participant based on how old the peer mentor is. So I think more unknowns than knowns to me at this point. For your question about digital risk for mental health, what's so interesting about this topic is that I know that there was a big book on this topic that everybody asks me about. I was giving a talk in Dallas a couple months ago, and people were like, what do you think about that book about digital mental health and anxiety and how technology is ruining the lives of kids? And I think the reality is, in the past 5 years, there have been huge calls from NAME research about what effect does social media have on mental health, because there's a lot of assumptions without a lot of solid data. There are some really concerning trends. For instance, you all have probably heard about the research on eating disorder risk among adolescent girls in particular. So there absolutely are some studies suggesting that certain kinds of populations are at certain kinds of risk based on what kind of content they're engaging with. But I think it's not the technology, it's the content on the technology. I also think that the youth desire for technology is not going to go away. And so I think it's really interesting, some countries are banning social media use for adolescents. And that is not a topic area that I research, but my intuition about this is adolescents aren't going to suddenly decide that they don't want to use this technology. And so In my mind, I think we need to be coaching youth toward, effective, safe guardrails. How can you use social media in a healthy way? How can you use technology for your betterment as opposed to your detriment? One example in STARS is we do have a forum, but it's a moderated forum. And so what that means is that when a youth, posts or a participant posts a question, it gets moderated by people whose job that is to track that and make sure that the content is appropriate and, reduce the risk of iatrogenic effects. Jose, you do a lot of work in this space. What do you think about that?
I was going to try to Gary before. I had some ideas. We've done some work scaling training for lay mental health coaches. And we've experimented with some things, some of which I think worked well and might translate to this around asynchronous training combined with peer practice sessions that are recorded with feedback. And so there might be opportunities to do some things like that or to leverage your more experienced peers as mentors, where newer peers could shadow them. So happy to brainstorm if any of that sounds interesting, because I agree, like the scalability feels like an important thing to start thinking about as you're moving into these next steps. This is really cool work. So thank you for sharing it.
Thank you. And I love the idea of making sure that the peers get experiential practice as part of their training, but that some of the didactics could be, asynchronous to make it faster. I think that's a great idea.
So thank you so much, Julie, for this presentation. And I apologize in advance, but this might be a contentious question.
Okay.
But aside from peer mentors, would you be open to looking at utilizing AI for some sessions and everything? I know right now, AI is doing the opposite and driving people to suicide. But I feel like at the end of the day, it's a technological problem. Like with enough training and guardrails, we can have AI do what humans cannot do. Like you mentioned, majority of the suicide happening in the middle of the night, where hopefully psychiatrists and peer mentors are asleep, but AI does not sleep. At the same time, I was also thinking about the language barrier. Currently, we are training peer mentors in English, whereas AI is able to transcend multiple languages.
Yeah, I think this is not something that I feel strongly about, but I think it's a fabulous question. And I don't know how many of you have had this experience, but what I use ChatGPT for is figuring out what kinds of journals I should submit to. And so I had an experience recently that was very therapeutic with ChatGPT, where I said, I submitted this particular paper, it was this huge review paper. And it didn't get accepted, and it's really long. So please find some journal outlets for me that will allow for this many words and this topic. And ChatGPT was like, first of all, I just want to start by saying, I'm so sorry to hear that. And I was like, ChatGPT for hearing me. And so there are some humanistic qualities that we can train in AI models. Are they human enough? Do people feel seen enough by them? It probably depends a lot on the person, and it depends on what they need. And so I think with the right guardrails, there's potential. There's also more research coming out. Even this week, I was seeing some people posting some recent studies on AI versus human therapists. And the reality is not all human therapists are fabulous at their job. We wish that they would be, but we all have days that we're not as effective as we hope to be. And so there is risk that a given clinician is not optimized, just like there's risk that an AI model isn't optimized in terms of ethical implications. So I think we need to be attending to it on all fronts. I don't know if anyone here does research on that you would like to add to the discussion about AI and mental health. I think especially the middle of the night piece is huge for that, because you're right, what options do we have, and are those options decent enough to get through until 9 a.m. when clinical services open back up? I think that's a very reasonable use case.
One last question to end on. As someone that's not deep in the research world like you are, I start thinking about wow, we should see this on the market in the app stores. This sounds like a more evidence-backed version of BetterHelp. Two parts to that. How do we make sure that it doesn't have the same pitfalls as BetterHelp, where people just sign up to be a therapist and do a terrible job? Second, what from a layman's perspective, like what does the future of this app look like for getting out to the larger public?
Oh gosh, what a big question. You know, it's so interesting. We have seen during the pandemic at our anxiety treatment center, we had these awful wait lists, like 8 months to get in for anxiety focused therapy. A lot more people are using BetterHelp now. We've seen a huge reduction in our wait list. Now it's like 5 weeks, which is too long. We want it to be shorter than that, but we're seeing fewer people reaching out for therapy, more people going to BetterHelp. And I think that there are opportunities there to make sure that the strategies that they're getting are actually evidence-based, because I think not everything that's on the market, as you said, is based on evidence or attending to the same like ethical guidelines that we would expect people to attend to. And so I do think there's the potential that a program like this could be scaled up, because I think the appetite is there in the public. Therapy is really hard to get into. Not everybody wants a therapist. There's all kinds of stigma-related reasons why people would prefer not to have to call, you know, a setting to get on the list for therapy. So I think having something that is more accessible is absolutely the future. And I think that STARS and programs like it could be a piece of that. But I think we need to be careful not to scale too fast, because I think that's one of the biggest challenges plaguing the suicide prevention space, is that there's excitement about an area, it gets rolled out widely, and then we learn it doesn't work. And then people get discouraged, and then they start to not trust scientists because they say, you said that this would work and it didn't work. You know, why shouldn't I just do anything that I think will be helpful? And I think that's really working against us. So I think we should be scaling up, but doing so really carefully and slowly.
I'm sure there's like many more conversations to be had. We have a reception if you're here, right outside. So please help me just thank Dr. Brown one more time. Fine. We'll see you next year.